Good morning, everybody. Welcome to Pediatric Grand Round. Today we have a great team approach to the ever-growing problem of pediatric obesity. We have Dr. Virginia Powell and Dr. Joy Collins. Dr. Powell is the section chief of the PICU with a master's in public health from Johns Hopkins and board eligible currently in obesity medicine with a strong personal interest in health and nutrition. Dr. Joy Collins heads up the Department of Pediatric Surgery and is the Associate Program Director for Gen Surgery. She has training in bariatric surgery in Pittsburgh and has been with the Carilion family for the last 3 to 4 years now. Please welcome Dr. Collins and Dr. Powell.
Hello. Dr. Collins and I are going to speak on the treatment options for obesity in children. Putting this lecture together, I have to really stay focused because there's so many tangents we could go off on. So some of the topics certainly may open thoughts for further discussion that we're just going to cover briefly today, and I guess we segue for future lectures. But we have no financial disclosures. The objectives are to examine the pattern, discuss some of the consequences, obesity-related medical problems in pediatrics, outline some of the basic medical treatment of obesity, discuss the medical versus surgical outcomes, and then review the current recommended surgical management. Obesity in the United States, we've heard lecture after lecture talking about the severe changes and how much more this is a significant problem. There's a series of slides that the CDC makes that you can actually put together as a loop that goes through how the map has changed over time. This is one of the earlier maps that they have where they could collect data. The white states in this one are ones where they did not have sufficient data to present. So the ones that do have data, the light blue and dark blue, correspond to a 10% and then a 10 to 15% rates of obesity being defined as a BMI over 30. This is to demonstrate some of the changes in prevalence with over each 10-year gap. You can see by 1990 they had data on most of the states. And again, in that map, the white were the states that they did not have data, which changes by the 2010. It's the states that are 25 to 29%. But you can see how the map is changing, where the medium blue color is the 10 to 14. The deep blue is the less than 10% is the light blue. 10 to 14% is medium, and 20% is the dark blue, and getting up into the 20 to 25% is the red color. And then when you look at the most recent map they had available, we've gone to the less than 20% is the stippled green, which there is no more at that point. The map before still had a little bit. I think it was in Hawaii. Colorado wins for the lowest obesity rate of all the states, and that's still in the 20 to 25% range, going up to a great number of the states with the burgundy color of greater than 35%. In the pediatric data, we don't have the individual maps for that to demonstrate, but this one is showing, let's see, is this my pointer? Yeah. This one is showing, this particular one is the total numbers, then you have male and female. The dark blue is the total with the obesity rate, and this is the most recent year of the data I could pull to get a graph on, and it's at the 18.5%. The younger age, this is divided by age groups. This is the 2 to 5-year-olds, 6 to 11-year-olds, and then 12 to 19-year-olds. And the percents go up with age. With the youngest group is at essentially 14%, 18.4%, and then 20%. Over the years among ages, the rate's going up, but also if you look at data over time, the childhood obesity rate has tripled in the last 30 years, and the current growth that's most concerning is that if you look at the weights divided up between obesity in general, mild obesity, and more severe obesity, it's the group with the more severe obesity that has the fastest trajectory of growth, which is very concerning from a health standpoint. This is state data. You can go onto the CDC website and some of the other websites and get individual data for various states. This is looking at the state of Virginia. We ranked 29th out of 51 states, counting the District of Columbia as a state. We have an average obesity rate among adults of 29.7. Our pediatric obesity rate is at 14.3, with 13% of high school students affected by obesity. This is very costly nationwide, and I'll get into that a bit in a more future slide. So the societal consequences of obesity, there are many. Just to cite a few, certainly shortened lifespans. The estimated average lifespan will be shortened by 3 to 5 years just based on attributed to obesity. And if you put all of the obesity-related illnesses together, it makes obesity the leading cause of death in the United States. From a financial standpoint, the estimated annual healthcare costs are just staggering. Those related to obesity-related comorbidities are estimated between $147 and $210 billion per year in medical costs. Childhood obesity alone is responsible for $14 billion in direct medical costs, and it equates to about 21% of our annual medical expenditure in the U.S. When they look at military recruits, recruits who are interested in joining the military, roughly a quarter of them have severe enough obesity that they're unable to enter the military despite wanting to. And then in indirect costs, things that are a little harder to measure, absenteeism from work that's attributed to comorbidities related to obesity, and then premature disability and premature death are all things that affect the ability as a society for being able to be productive work and earning money. The definitions with the diagnosis of obesity, for adults and physically mature teens, you would use the BMI chart with the absolute BMI number. A BMI of 25 to 30 is considered being overweight, and 30 and over is obese. And if you delve into it further, there's different classifications of stages of obesity, up to severe obesity being over the BMI of 40. And those are looked at a little bit differently in terms of risks for comorbidities and treatment options, and at what point do you offer more severe treatments. In pediatrics, you can't really look at absolute BMI because the absolute numbers don't necessarily correspond to obesity. But if you've looked at the BMI chart, which if you put in a height and weight for your patients on their routine visits, it will automatically populate the BMI chart, which you can access on Epic and is listed in the flag of some of the important vital things. If you look at that, the absolute BMI number is not what we use in pediatrics, but they're percentile. So the percentiles are what the obesity diagnosis is based on. Underweight is if the BMI is under the 5th percentile. Normal is a wide range of the 5th percentile up to the 85th percentile. And 85th to 95th is considered overweight. 95th to 99 is obese, and over that 99th percentile is obesity, with severe obesity being over the 120th percentile. And that's quite concerning because that's the group that's increasing the fastest in our historical data. BMI, just to remind everyone, is the weight over the height squared, and you can calculate it with kilograms over meter squared. There's also a formula using inches and pounds that has a factor in there to accommodate. But things with BMI, it's a good tool to use from a population standpoint. When you're looking at an individual, you need to look at the whole individual. It will help you look at that number, but there are individuals that might have an artificially high appearing BMI if they have a high non-adipose weight, i.e. you're really buff football player. His BMI is going to be high, but it's not adiposity. The majority of the patients we see, it's going to be adiposity and to be addressed. Just to get a visual on this, these are the BMI age percentiles. These are percentiles, not the absolute number. The dip down and shape for the BMI numbers. Some of this has to do, if you think about, we're looking at the weight divided by the height squared. So depending on what normal linear growth is doing versus weight changes, it has to do with the way the growth chart curves. Gives it kind of an odd look when you're thinking of it more as a straight line trajectory. And this is an example in terms of what the BMI means numbers-wise. The example given here in terms of how to look at this and why it's important to look at it on the percentile chart. If you have this is an example of a 10-year-old boy with a BMI of 23, and in a 10-year-old boy that was a BMI of 23 would fall in the obese range, where a 15-year-old with the same BMI would fall into the normal weight range because their percentiles are different. Unlike adults where we can say an absolute BMI, in kids it's the percentile. And I did the math backwards using a 50th percentile height. In the 10-year-old in this example, it would end up being, if he was at the 50th percentile for height, he would be 4 foot 6 inches, and his weight would be about 95 pounds to make the math work. And then by 15, he's grown to 5'9", and his weight has gone up to 146. So even though he's gained weight, his growth trajectories for linear growth has compensated, and it throws him into a lower BMI. Looking at just to emphasize that looking at the percentiles is what's important and not the absolute number in the pediatric world. Medical consequences of obesity, there are lots and lots of comorbidities. There's lots of charts similar to this you can find online. I like this picture, so I picked it, but some of these we hadn't even really thought about in the past. But adiposity in of itself is a chronic inflammatory disorder, and it will trigger other inflammatory problems, and that leads to some of these comorbidities. Psychosocial, poor self-esteem is a big one. These kids, when quality of life scores were done, this was in the news quite a bit about a year ago, but children with obesity answer questions in terms of what they see as their quality of life very similar to children with active treatment for cancer. So they're sort of at the bottom of the heap for self-reporting of quality of life. There's a lot of bullying, there's a lot of depression, certainly as you get older. They are not protected under the handicapped individuals laws, so that you can discriminate against people for obesity without there being a legal repercussion. And I think that starts for kids even in younger ages. Pulmonary, with that inflammatory factor, they have a higher rate of asthma. They have sleep apnea, which is just going to continue the cycle, because without adequate sleep, we'll actually produce more ghrelin, which is your hunger hormone, and drives you to eat more. So the cycle can be quite negative. The poor pulmonary problems will lead to exercise intolerance as well, for shortness of breath. GI-wise, they have a high rate of children with obesity have a high rate of gallstones. They have about 40% have gastroesophageal reflux disease. They're at high risk for the non-alcoholic fatty liver disease, and that can eventually lead to cirrhosis. Renal defects, they have increased kidney stones. You can have incontinence related to obesity. That could certainly add to the psychological embarrassment if a child has problems with incontinence. Musculoskeletal, there's lots of problems related to that, with slipped capital femoral epiphysis and Blount's disease, which is a slipping of the tibial growth plate causing a bowing of the legs. Those two are unique to pediatrics in terms of a risk for obesity. They have a high risk of degenerative bone disease, joint disease, and about 60% of patients with children with obesity will report joint pain. So a pretty high percent are feeling the effects of their weight on their joints. Neurologically, there is an increased risk for pseudotumor cerebri. There's cardiovascular disease with hypertension. Hypertension is about 25% of children with obesity will have hypertension to some extent, and the risk increases with the percentile of excessive weight. Left ventricular hypertrophy is resolved. The chronic inflammation can lead to endothelial dysfunction and increase the risk for other cardiovascular disease events. Endocrinopathies, and we think about this a lot, and they're seeing an uptick, is type 2 diabetes. It's thought that about 25% of adolescents today have prediabetes, which is a staggering number when you think about 25% of those are going to go on to the type 2 diabetes. An increased rate of polycystic ovary syndrome and hypogonadism in males and gynecomastia. So quite a long list of medical consequences that we need to think about when we're identifying these kids and reviewing their issues in the lab, in the clinics. Other things associated with this is association with childhood obesity development, things that should be red flags to think about. A lot of these could be a lecture in their own, and was fascinating. I was just at the Overcoming Obesity Conference, which is the twice-a-year annual conferences for the American Obesity Association. There were entire lectures on epigenetics, which is just fascinating to me. But parental obesity is a big trigger, and we think about just the social situation being part of it and the food choices that you're thinking the parents may be making. But there's more to it than that. There's actually changes happening in utero. If one parent is obese, the child has a threefold incidence of having obesity. If both parents have obesity, there's a tenfold chance. So it's pretty staggering, and it really pushed addressing it to childbearing age parents, that getting their weight under control before conception will help a child have a normal weight. Being LGA or SGA has been associated with obesity later in life. The explanation, as I understood it in the lectures for SGA, and I had trouble finding anything in writing, was that they felt like the formulas we use for catch-up growth really add to more of an adiposity growth as opposed to non-adipose tissue being, there's some of it, but from a percentage standpoint that they develop more fatty tissue early on. Maternal smoking, and that's independent of its contribution to small for gestational age. Not just being formula-fed, but bottle-fed, and that thought is that parents have a goal for how much their child needs to eat, and they will keep that bottle going in the mouth until that amount is consumed, and that's breast milk or bottle milk or formula. So breastfeeding naturally, where you don't really have a measured amount of how much the child is taking, is felt to decrease your focus on the volume that the child's eating, and that they can self-regulate better, and that they learn self-regulation at that age so that later in life that their eating patterns are better. Early introduction of foods, and for similar reasons. Sweetened beverages, back when I was a resident, we were advocating for not using sweetened beverages, but using the dental caries as a big reason. But a lot of calories are consumed in beverages, and those calories, the beverages tend to not fill you up as much as food, and a lot of increased weight is attributed to how much sweetened beverages the American population drinks. Eating out of the home, and again, a lot of these associations in different lectures I've been to, they've taken a graph of the significant trajectory of obesity in the American population and then compared it to other things with similar trajectories. So they had how many meals we don't prepare in the home, how many times you just pick up food on the way home from work, and then how many meals are eaten in the restaurants. And both of those numbers have increased dramatically, where over a third of our meals are not prepared in the home anymore. Screen time, and that had a pretty strong and impressive graph in terms of how much that correlates to weight gain. And then lack of adequate sleep, and there's hormonal reasons for that. Being sleep deprived will trigger your ghrelin secretion, which is your hunger hormone, and make you feel hungrier. So you may not really have a food need from a caloric standpoint, but your emotional or hormonal feeling is that you're hungry. The probability of going on from having pediatric obesity to adults, and these are to some extent kind of saying the same thing in different ways, but every increase in a pediatric patient's BMI percentile is associated with an increasing risk of developing adult obesity. So children with obesity that are closer to the 85th percentile, the upper limit of normal, are much more likely to be able to change their body proportions as they grow so that they'll eventually be in a normal weight range as an adult. For example, the sample I gave, where if you said that child where they were with a BMI of 23 at 10 versus 15, they've had a growth spurt in height while they've kept their weight in a less of an increased trajectory, so that the actual BMI percentile has improved. The younger a child is when obesity is recognized and addressed, the less likely they are to become obese. So, and that makes sense intuitively, that if there's various eating and exercise habits you have, the younger you address that and make changes, the greater the likelihood that you're going to be able to change those habits and keep them as you get older. If you have an older child with a much higher BMI, your likelihood of success is much less, and they're much more likely to go on to have adult obesity. Genetics, and this is, I'm not going to go into it again, this is a lecture in and of itself, but there are several genetic conditions. The take-home in terms of your general evaluation of patients in your clinic is that the genetic conditions that are associated with obesity, for the most part, you're going to have identified younger in life, probably in the nursery for a lot of these. Prader-Willi is the highest, most concerning one in terms of kids that will have obesity. With Prader-Willi syndrome, this is a deletion of the Q11 to 13 region. They have hypotonia at birth. They actually have a lot of feeding difficulties. You're likely going to diagnose this child in the nursery because of abnormal facial features in terms of and hypotonia, difficulty feeding. It's a kid you're going to struggle with and may have a feeding tube because of being slow to gain weight and being failure to thrive. By around age 2, however, that difficulty in feeding turns around. They have hyperphagia, and it becomes quite a struggle for parents. These are the kids that you have to lock the refrigerator and the cabinet so that they don't get up in the middle of the night and go and eat everything they can. They just have no sensation of satiety, and so they'll eat for prolonged periods of time and are quite difficult to treat. The Bardet-Biedl syndrome is also associated with obesity. Those kids have visual issues, polydactyl, and mental retardation as other components of their disorder. So again, these are just conditions you're going to have diagnosed ahead of time and just need to be aware that they can be associated with obesity and that parents may need a lot of support to help them children from developing obesity. There's some other things that are more related to the satiety pathways, the POMC deficiency and the MRC4 deficiencies, and those and congenital leptin deficiency. Leptin is your satiety hormone. Those conditions are, I think it seems as if a lot more research is going on right now in the field of obesity medicine to look at those deficiencies and how common are they, and some newer ones that are coming out with defects in the satiety pathways. But in the big picture, a very small percent of the patients diagnosed with obesity have a genetic reason for it in the true genetic picture. Hypothyroidism, I have to throw this in as an extra when we're talking about what kids are born with and would lead to obesity. Congenital hypothyroidism is an inadequate production of TSH. We check for this in the United States on the newborn screen, so this should be diagnosed and treated as soon as kids are born, but some other countries don't diagnose it in the prenatal period, in the neonatal period. These kids have poor muscle tone, again, initially have poor feeding problems, but as they get older, they'll have slow linear growth, but they'll have some degree of obesity and intellectual disability. So, again, a lot of the patients that have an underlying genetic or metabolic error at the time of birth that would lead to obesity, have other things going on. They tend to have the more rapid weight, when they have the more rapid weight gain, when you look at them proportionally, that their stature has not kept track with it. If it's a weight gain from more calories in than calorie out sort of equation, then you tend to see linear trajectory going hand in hand, so they'll have normal growth curves in terms of their height, but the weight is out of proportion. I think our endocrine group can attest that every child identified as overweight, the parents will ask you if it's their thyroid and should they check it, and so I just threw that in here. But Worldwide, iodine deficiency is the main reason for hypothyroidism, but within the United States, most of the true hypothyroidism is more likely autoimmune in our adolescent population. Surgical removal, that's what's going on, and they're going to have replacement from surgery on. But you can look up a whole list of hypothyroid symptoms, and certainly if a parent asks to review those and make sure that this isn't someone you should be sending for. So when a patient comes into your office and you're reviewing their growth charts and you're concerned that they have obesity, things to go through. Get a weight history. You may want to ask questions about their birth weight and their growth trajectory. If this has been something, you're getting a red flag because they started with failure to thrive or had other birth issues, you might identify a younger child that has one of the genetic defects, but for the most part, those are going to have been diagnosed before you're seeing them. There are concerns with overweight as a teen is to ask and get a sense for the trajectory. Someone that's just had a gradual increasing weight that's, and you can look back at a growth chart and it's not like they've had a dramatic sudden increase. Those are probably more of a behavioral eating pattern that dieting may be helpful for. Someone with a very sudden, and I think about females more than males, but that's not necessarily a fair statement. Thing to think about is this is often something that someone that's being sexually abused might do as a defense to make themselves less attractive. And it's a bit unsettling looking at the literature of how important it is to screen for sexual abuse in your obese patients with obesity to make sure this isn't a defense mechanism to try and hide themselves and make themselves less attractive from a sexual standpoint. Getting a sense of their intake, asking about sugary beverages, asking about the eating environment, family history, are there other weight issues in the family? We know that there's that increased risk with a family with obesity, and oftentimes your approach with a child really needs to be a family approach to eating changes. Looking for hormonal issues, patients with obesity have a high risk of type 2 diabetes, so you want to screen for that and think about it and talk about it. And then the social history, getting a sense of their school achievement. This might be a red flag to look for some of the genetic disorders, but also whether there's bullying or obstructive sleep apnea. They may not perform as well at school. They may actually have ADHD because they're not sleeping well, or behavioral problems. Ask them about physical activity, and I'll just go into that briefly with a slide. And then psychiatric, not only what effects that having obesity has on their psyche, but also getting an assessment at that time if there's a willingness to change. There is definitely a need to look at the growth chart and speak with parents about it. They're going to be very sensitive. People don't like to hear the comment, your child has obesity. It's very considered a negative red flag. They don't like to hear it. But if you're not aware of the problem, you can't fix it. It's important that parents realize that the growth trajectory could be that child is going to become very overweight, and that can be associated with so many comorbidities that it's important to treat it when they're early in those stages. If you have that opportunity to identify the patient that BMI curve is in that just overweight range and not yet up to obesity, so that you have a higher success rate with treatment. Using wordage that sounds a little gentler to the family often will encourage them to speak about it more. Even pointing it out on the growth chart and then just offering, would you be open to talking about your child's weight concerns and ways that we can address it? Parents in studies have been more receptive to that sort of language than just saying, your kid's fat, we need to treat them, or you need to do something. And then giving them some tools, and we'll talk about that a little bit as part of my part, and then Joy's going to talk about the more extreme end of treatment. So recommendations for physical activity, I threw this in, and again, I think that could be its own talk too. But for the school-age child, the recommendation is just to keep them physically active throughout the day, that they should be encouraged to have active play and a variety of activities. Going against sort of, getting your kid in soccer from age 3, and then you're just pro-soccer for everything, but a variety of activities so that they're exposed to different types of movement and consider it enjoyable, and encouraging that they're physically active and not parked in front of a TV all day. Children that are school age should have at least 60 minutes of aerobic activity per day and more if they can get it. Virginia is not a school that requires phys ed, and there's no set guidelines as to how many minutes of phys ed per day. There's so much push to have less time outside of the classroom that kids just don't get a chance to move while they're at school during the day, and then even in elementary school go home with homework, and then with daycare situations have a high risk of being, again, parked in front of a screen of some sort. And just to carry through for adults, the recommendations for all of us for physical activity is 150 to 300 minutes per week, moderate activity, or you can shorten that if you do more vigorous activity. So this correlates into 30 to 60 minutes a day of physical activity. Chronic medications are important to ask about. There's quite a number of medications that can contribute to weight gain. There's multiple antidepressants. The antipsychotics and mood stabilizers can all lead to weight gain. There are different hormones and steroids, so you take that child that already has obesity, they have asthma, and you're putting them on prednisone, that's just going to make the problem worse in terms of their obesity. So trying to be aware of those medications and looking to see if there's alternatives. There are other antidepressants, Wellbutrin being one that's less likely to cause depression. Of the serotonin ones, there's some that are more likely than others, but all of them have a little bit of tendency towards weight gain. In terms of your review of systems, a lot of these are looking at for the comorbidities that we already talked about in detail, but asking about obstructive sleep apnea because there's going to be a high percent. A TNA may help, but it's not going to prevent the majority. The majority, it's going to be weight loss. They can benefit from CPAP, but it's got a very low compliance when we prescribe it. Certainly asking questions about asthma, screening for non-alcohol fatty liver disease, symptoms for gallstones, reflux, constipation, evidence for type 1 or type 2 diabetes, polycystic ovary syndrome, Cushing syndrome, early onset puberty can be associated with obesity, pseudotumor cerebri, dyslipidemias, psychiatric disorders. Blount is again the tibial growth plate, so being affected by the increased weight. So bowing of the legs, the slipped femoral epiphysis, acanthosis, nigra glands, and vitamin D deficiencies are all things to think about and ask for support. On your physical exam, in addition to just all the usual stuff we look at for vital signs, it's important to make sure you've done a blood pressure because the rate of hypertension is so high. With the concern for kids being nervous about their blood pressure being taken, white coat disease, I think just compound it with kids screaming while you're taking the blood pressure and attributing it to that. The recommendation for diagnosis of hypertension is that you have 3 separate blood pressures on 3 separate visits to the physician, so not even just repeating it several times in the office on the same day, but to get separate readings before you give them the diagnosis of hypertension, but that does need to be addressed if you find it. Skin, that you're looking for the acanthosis nigricans, and we certainly see kids where the mother says they thought that it was just dirt on their neck and they weren't bathing properly and go scrub your neck. They can also have infections and irritation in skin folds that they may be embarrassed about and may cause odors that just add to their bullying and psychological problems. So those are important things to look for. They can get hirsutism, gynecomastia, ask about joint pain because the majority of kids with obesity are going to have it. And then looking at their sexual maturation as well. You may see precocious puberty from the increased adiposity contributing to the secretion of hormones. Laboratory evaluation, there's not a lot of labs recommended when you start working with a patient that you're worried about their weight problems. And I know that we have a push in our outpatient department to get lipid profiles on all of our patients, but certainly you want to look at that in the population that has elevated BMIs. You also want to think about their ALT and AST indicators of development of the non-alcoholic fatty liver disease, and think about things like what their hemoglobin A1C is, what their fasting glucose is in terms of development of prediabetes and diabetes. And also, you can consider thyroid studies if you're getting any of those symptoms we talked about before with thyroid disease. In terms of treatment, a lot of the treatment, particularly in the younger ages, is more of decreasing screen time, increasing exercise, and maintaining weight while you're making behavioral changes. You really don't want to push a lot of actual weight loss in the milder obesity diagnosis, but with the severe obesity, even in that 2 to 5 year old, you would want a calorie deficit diet to cause some weight loss. But even then, you want a slow weight loss. You don't want this child to have a dramatic weight loss. That just sets you up for the other spectrum of unhealthy eating, and you do need to keep in mind with treating childhood obesity that you want to be careful that the emphasis is more on health, and that weight loss only needs to be about 10% of body weight to have an impact on their comorbidities and making them a healthier individual. So your goal isn't to get skinny per se, and you want to have a red flag out for someone losing more weight than your goals because of concerns with things like anorexia developing. 6 to 11 year olds, similar, you can allow for a little bit more weight loss in those kids that have a higher degree of obesity, but still you don't want something real dramatic. And in the teenagers with more of an adult physiology, can see a bit more weight loss and be in a safe range. But again, that's an age range where you're really going to be worried about the other end of the spectrum, and you want to watch for that. For medical weight loss, a lot of this is reiterating things I've just said, but better outcomes if you start with younger kids at younger BMI, at earlier BMIs. So looking at that BMI chart, finding the child that it would diagnose and fall into the overweight but not yet obese category, and talk with the family in a way that hopefully they're receptive to about the simple changes you can start to make to promote a normal weight without necessarily even a weight loss, but keeping the weight stable while they're growing allow for the BMI to improve. Treatment really depends on the family recognizing that it's a problem. And I have had personal experiences seeing parents very offended by being told their child has a high BMI. One family that I sat in a waiting room at the gymnastics center listening to them, the child had come home from school that day with a note from the school nurse that they had done weight and height screening and that her BMI was in the obesity range, and that they needed to see the physician about this. And they were parents that I would guess their BMI would be close to 40, sitting there just furious that anyone would accuse their child of being overweight. And she was probably a BMI, a percentile that was above that 95th percentile. So you sort of sit there judging and thinking, how can they not see it? But at the flip side is just that they're very offended by hearing it. And so we want to be gentle in how we say it to parents and making sure that we're not offending them and alienating them and making them not want to come in for appointments, which can certainly be a difficult line to walk. Unlike other conditions that have less of a stigma, it's easier to say your child has X, Y, and Z, and this is the treatment. And part of the problem with the treatment is that we don't have a perfect diet to treat it with. We don't have all of the clear answers, and it's a group of behavioral changes that are not always easy to make. Lifestyle changes are what are associated with prevention and are the first things to recommend for treatment. When you have the opportunity to intervene for breastfeeding, and I know I'm speaking to the choir on that, but recommending breastfeeding and exclusive breastfeeding until 6 months of age, and promoting feeding at the breast as opposed to pumping and feeding from a bottle. avoiding sweets, and not being regimented on this where you're just absolutely can never have anything sweet to eat because then it becomes the desired forbidden fruit. But keeping track of it, not offering lots of sweets, having less in the home, but not something that's a part of their everyday life. Meeting the recommended activity guidelines that we spoke about, eating plenty of fruits and vegetables, eating meals as a family, and limiting screen time. A lot of these, when they're listed as changes that are helpful, have controversial data. They don't have any clean lines that can say, by changing this behavior, you're going to get this outcome. But I was impressed looking at the screen time, that there's a study looking at how many hours of screen time children report, or families report that their children have, and then the percent of those kids that were overweight. And it goes up linearly. So it's pretty impressive to see that. Looking at it from a staged approach, the recommendations from the American Obesity Association with pediatric treatment is certainly depending on the degree of the amount of obesity a patient has, going from overweight to stage 1, 2, 3, and that's looking at what percentiles they fall in, to have more aggressive treatments. The first two steps, looking at a patient that is at risk for obesity, where you've diagnosed, you're aware that the family has obesity problems, or a child that has disorders, i.e. the Prader-Willi that is at high risk for obesity, talking about it before it's a problem, talking about it as soon as you see it as overweight versus obesity. Those are things that as PCPs we should be looking at treating. Getting into more aggressive dieting, talking about whether or not to prescribe medications. You may want to look at obesity treatment centers and bariatric surgery centers, things of that sort, as you go further along. The stage 1 is referred to as prevention plus, and these are things that are, I think, intuitively what we would think of and are things you're probably already hopefully doing in your clinics, but minimizing or eliminating sugar-sweetened beverages, limiting how much you eat out or carry food in from outside places, doing more cooking at home. And that's a whole family lifestyle thing, and for some families that is a big deal because they work long hours and it's a lot easier to pick up, carry out on the way home from work than to come home and try to fix a meal. There's a series of commercials that they showed at one of the conferences I went to that's a push in California for this, of how to make fast food healthy. And they were talking about how much better it would be rather than you go through the drive-in at one of the chicken places and get the chicken dinner with the fried chicken and mashed potatoes, if instead you go to the grocery store and get the rotisserie chicken that most stores already have prepared, pick up a bag of salad greens and some fruit or something and have that as your meal, where it's maybe because you have to get out of your car, it's a few minutes. I just don't know that that's enough dollars to do the click-it thing. But you can run in, pick up a few items, and run out, and you've gotten your pretty much a meal put together with very little work at home. So how to make fast food healthier. Making sure there's plenty of fruits and vegetables per day, and particularly with the fruits, that does not count fruit juice. By taking the fruit in with the fiber associated with eating a natural piece of fruit and not the juice, the sugars are going to be absorbed more slowly. It's going to be a more even blood sugar response. You're not going to trigger an insulin response. And so the way your body processes the food is much more of a healthy way in terms of our future blood sugars and risk for type 2 diabetes. Increasing the amount of family meals together, and certainly we've heard that for lots of different medical problems. You see that with issues with depression and drug abuse, et cetera, et cetera. So I can't say that enough to families. Allowing children to self-regulate their eating, limiting screen time, and encouraging increased activity. And the two I have starred are the ones that have the strongest evidence of being helpful in preventing diabetes, is allowing to self-regulate eating, which goes back to the breast versus a bottle eating as well from infancy on, and then limiting the screen time that has lots of studies that are showing increased obesity with increased screen time. Stage 2 would be all of the same, plus looking more at the actual calorie content and monitoring that and trying to structure feeds a bit more and having family really focus more on that increased physical activity. The comprehensive multidisciplinary, when you're getting into the more severe obesity, not only would be limiting caloric intake, and in some cases significantly limiting or doing something like meal drinks or bars in replacement for actual food, but in a more structured behavior modification program with some counseling. And for those, you want more of weekly visits and to start to think about medications. Stage 4, which is more tertiary care, and Dr. Collins is going to come and speak on that in a few minutes, would be not only the very low-calorie diets, but also introducing bariatric surgery. So quick thing on pharmacologic, and I'm running out of my time. I want to leave time for Dr. Collins. But in pediatrics, there's only 2 approved medications. Orlistat is approved for children over the age of 12. That prevents the absorption of food. It is over the counter. It is very poorly tolerated and not liked. It will cause stools, and that in itself can add to the child's embarrassment and difficulty. So for most people, they reject it. Metformin does have FDA approval for type 2 diabetes in kids over 10. Lots of people, a fair number of physicians treating pediatric patients with obesity are using it for pre-diabetic conditions to help, and it does contribute to some weight loss. It's not a dramatic amount of weight loss, but compared to similar patients that aren't taking it, you will see an increased weight loss with the same activity diet attempts. There's other medications, but none of them have been studied and approved in pediatrics, so I'm not going to go into detail on them. I'm going to skip questions at this point to let Dr. Collins get started, and we can do the MOCs at the end or now. So okay, so you have a 5-year-old girl adopted from Guatemala, and she presents to your office for a visit. She currently plots on the growth chart in the 3rd percentile for height and the 85th percentile for weight. What's your best next step? You want to get a bone age radiograph, or thyroid function test, you want to prescribe a calorie-restricted diet for her, or inform the parent that these findings are normal because she's of a different ethnicity. Actually, I'm going to order thyroid functions, and this.
We want a B and C.
You want B and C, okay. So for this child, what they're trying to get at, and this could appear on a board, this was actually taken as a board question, was that they're from Guatemala is your key phrase. They're not from the U.S., and so you're worried about a congenital disorder. The second one, what behavioral change can you recommend to your patients to have the greatest effect on preventing obesity? Recommend that they eat a vegetarian diet, suggest the whole family train for a 5K, limit screen time to 2 hours per day, or it's all related to genetics and there's really nothing you can do. Always go to Dr. Doherty. Yeah. So, yeah, it's endocrine. It's got to be the thyroid. So. And the takeaway I wanted was that the limiting screen time is something we do have evidence for. Some of these other ones might not be bad suggestions, but this is the one we have the most evidence for. And it's time. All right.
Before are there any questions for Dr. Powell? I don't want to.
And I can stick around afterwards.
I don't really have a question, but I just wanted to mention where you were talking about screening for thyroid. It's not uncommon to have a slightly abnormal or elevated TSH. So you kind of keep that in mind when you are screening for it. It might be that different antibodies to make sure that's not true. They get the problem.
I would bet most come to you all the time.
A lot of them, yes, they do. And a lot of times they're sent because they have an abnormal TSH, but it's usually like 6 or 7 and they're overweight, but the thyroid is not the problem. TSH is elevated because of the obesity, not the other way around.
A new program that Carilion is offering. Are we doing anything new?
We would like to be. That's my goal. I will be sitting for the obesity medicine board and my Yeah, and I might end up skipping to that because we have like a little less than 10 minutes left. And I just want to, like Dr. Powell said, we could talk about any little nuance of all of this for a whole hour. So I'm kind of happy to come back and talk more about surgery, especially as it becomes more relevant when hopefully she's freed up and we can get a program started. But I just wanted to reiterate her point about how much it matters relatively early in life. When we're talking about surgery, we're usually talking about the most extreme levels of obesity, and we're talking about older teenagers. And, I don't know if anybody's aware of the 2016 study. It's an Israeli study looking at 2.3 million adolescents. The study was conducted from 1967 to 2010, and so they had 40 years of follow-up, 2.3 million. So a lot of power, and they looked at the mean age of the adolescents at the beginning of the study was 17. So they looked at where patients were in terms of their weight and body mass index at 17, and then they followed them the rest of their life. And they split them into age and kind of weight categories that are typical of the CDC. And where do you think, this is kind of a pictorial representation of different body mass index levels, which I think essentially fits with the pediatric percentile levels pretty well by the time people are teenagers. So where do you think they found a significant increase in cardiovascular death early in life? They only followed them up for 40 years, so these people died by the time they were 55 or 60. Where? Here? Here? Yeah? Here. This correlates with a 2007 New England Journal article looking at over 600,000 Danish students in young ages. And patients who had about 5 kilos overweight in the 7 to 10 age range for boys and 7 to 13 age range for girls had a significantly increased number of cardiovascular events and mortality in about midlife. So that's worth, and so I just want to mention that, and I'm going to kind of probably go right to the end and we can talk about nuance later. But this is why surgeons don't like to wait. We worry a lot. I think that the pediatric literature has been fairly clear about this, that you don't have to be here to have all the problems. And even if you're here and you don't have problems when you're 50, you're in trouble. There's a lost years of life associated with this. And so I'm just going to mention really quickly the basic indications, the operations we're hoping to offer, and then talk a little bit about the program. So it used to be that indications for surgery, these are sort of mirroring the indications for surgery in adults. It used to be that we would wait till adolescents got to a BMI of 45 or 50, and what we were finding is that they had 4 or 5 or more comorbid conditions which made their surgery riskier. So by and large, if somebody has a body mass index of 35, or they're 120% of 95th percentile, or more than 40 without comorbidities, more than 35 with comorbidities, and they're willing to adhere to the treatment, they show up for medical weight management visits. And really, when you have an adult who is of this weight and they're interested and they have medical problems and they're interested in bariatric surgery, really the limiting factor is how quickly can you get this through the insurance company approval system. For adolescents, we take a very different approach, and typically these patients have been in treatment by you guys and hopefully by a medical weight management team. And because the patient and the family has to adhere to recommended treatments pre and post-op, and these are fairly onerous, like behavioral changes that are hopefully going to sustain them their whole life. One thing that's relatively new, if you look at the American Society for Metabolic and Bariatric Surgery updated 2018 guidelines for pediatric and adolescent bariatric surgery, there's no specific age recommendation, but I will tell you that for the most part, in this country, people are talking about teenagers, usually mid to older teenagers, although that may be changing over time. If there's a medically correctable cause of obesity, it's typically a contraindication for surgery, as is ongoing substance abuse problem, major mood disorder that's not actively treated, and current or planned pregnancy within. This isn't usually an issue with the adolescent population. This is typically an issue sometimes with older women who've been struggling with infertility. But we look for red flags, and the screening process is quite stringent, as is really the attempt to give these patients a chance to achieve sustainable, satisfactory weight loss and improve their health. The comprehensive weight management would take at least a 6-month period. In my personal experience, patients take about a year. Some take a year and a half to really be ready.
And they have to have the maturity to understand the risks. And this is ultimately going to be in question over time as the age goes down. But really what we're looking for is we're looking for patients that are really going to get the most out of the surgery as a tool for their weight loss and have minimal risk. I'm going to skip through some of this. So what we're shooting for here is a true multidisciplinary program. I don't think that it is safe or appropriate, nor do the governing bodies anymore, that it is safe or appropriate to do this with just a bariatric surgeon and a nutritionist. There needs to be a bariatric surgeon, hopefully someone who's used to taking care of kids, but in the appropriate pediatric-focused program, this could be an adult bariatric surgeon. You need a pediatric medical advisor, which is typically a pediatrician or somebody with subspecialty training. Sometimes it's endocrinologists or GI doctors, and it really, these folks can get boarded in obesity medicine, as Dr. Powell is doing, and donate a significant amount of their time. This is a very time-consuming job. Behavioral specialist is absolutely crucial. This can be any one of a variety of people. It's frequently a psychologist, but they're specifically trained in adolescent and family dynamics, weight issues, and in particular, there's typical special training that needs to be done to evaluate these patients for a preoperative process. And, you know, a little bit less stringently monitored are these folks, but I really think you do need all these, you know, program coordinator, definitely a nutritionist, physical activity specialist helps a lot. A lot of times these patients don't know what's appropriate to do in terms of exercise, and they need a lot more help than go home and watch some videos or here are a few printouts with some exercise diagrams on them. And then obviously they need specialized consultants. They're going to be seeing endocrinologists. They're going to be seeing GI specialists for the non-alcoholic fatty liver disease, which is soon to be in young adults the #1 cause of need for transplant due to obesity. They're going to see the cardiologist, so we need dedicated folks for that. And probably the last thing I have time for is you all probably know that there are a few surgical options in kind of chronological order. The gastric bypass, which involves creation of a 1-ounce gastric pouch and rerouting of the intestine to bypass the portion, is the gold standard and has been in utilization for many decades. It was the first procedure performed on adolescents. It has its downsides. The gastric band never got out of the study phases. For adolescents in general, doesn't really work for anybody anymore. It's very hard to find centers putting them in, even in adults. And then there's the rise of the sleeve gastrectomy, which involves creating a 3 to 4 ounce sleeve-shaped gastric reservoir with no intestinal bypass, and that is increasingly the procedure of choice in adolescents, although there are patients for whom that's an inappropriate operation and a bypass is a better choice. Our goal is to develop a multidisciplinary program involving all the components that we mentioned and primarily offer a sleeve gastrectomy and follow these patients frequently for life. And I think that's unfortunately all I have time for, but I have to take questions.
Oh, sorry, quick question, thank you for this. We keep talking about like finding kids at younger and younger ages and doing interventions, but I mean, so many little babies are just puddles of adipose tissue. At what point, like, is that not okay anymore? Because, you know, like a 6-month-old is commonly, you know, pretty high on BMI.
Yeah, I'd probably defer the answer to Dr. Powell for that.
Yeah. For the under 2-year-olds, they say to look at the weight for length on the growth charts in terms of classifying them, but I didn't see any recommendations that you should work on weight loss, but just to start counseling on trying to sort out, number one, that is the age group that you're going to think about. Is this actually more of a genetic disorder? And identifying that. And again, those kids might be more failure to thrive than weight gain at that stage, but also just reiterating the feeding habits and what they're feeding the child. Actual weight loss isn't going to be your goal in that group.
And I think it's really going to be, hopefully, prevention and management at the earlier ages. And talking to families about that is going to be helpful. I see a lot of patients who come in for they're not interested in talking about their weight. They have surgical problems that are either created by their weight or made more difficult by their weight. And when I have these discussions, it's like the first time they've ever heard it, and it's hard for me to have a productive discussion about it. So I agree with Dr. Powell that those skills and starting early are important.
Dr. Collins, can you just briefly mention advantages or differences between the Roux-en-Y and the sleep gastrectomy?
That's a little bit of a long discussion.
Well, nutritionally, is there any difference as far as after surgery?
Yeah. Nutritionally, it's a little hard to know. We don't have the best data on that yet because there are nutritional deficiencies with the sleeve gastrectomy that you might not really expect without the intestinal bypass portion. Iron deficiency anemia is the most common. B12 deficiency is fairly common. And although these patients typically present to you already with vitamin deficiencies, which is another one of the things that the medical weight management folks kind of screen for and try to correct ahead of time, both of the procedures that are commonly done require lifelong nutritional supplementation, vitamin supplementation. It's not quite as many or as high doses for sleeve gastrectomy patients as gastric bypass patients, but they do require lifelong vitamin supplementation, which is really hard to get compliance with. They typically don't have as many of the bigger nutritional deficiencies. Overall, it's surgical risk and complication that are less in the sleeve gastrectomy patient.
Is part of the reason that the sleeve is taking off, just out of curiosity, is it because if the term we use in adults is beat the surgery, and they can convert to a Roux-en-Y and potentially as an adult? Is that something that's being done?
Yeah, I don't think that was the original intent. I think what's attractive about the sleeve is that it takes less time to do it. You know, the less you do, the fewer complications there are. And we've actually seen pretty astounding weight loss and comorbidity improvement with sleeve gastrectomies. And there's not a lot of data yet on adolescents who regain weight, but the thought is that it can be revised to a bypass or a duodenal switch or another weight loss and metabolic procedure down the road. I think it's going to take a decade or two before we kind of see those patients coming back and requiring that and then seeing how they do. But theoretically, it is an option, so that's kind of attractive. I can come back and talk specifically about a lot of the data. There are some higher volume centers that show at least at 5 years after sleeve gastrectomy, comorbidities don't come back. For the most part, weight regain happens. It's not a huge problem, but as we collect more numbers, we'll find out. Okay.